taking into account that sometimes not all AVF complications are symptomatic, or at least detected by simple monitoring, would you think a periodical surveillance, for example, with ultrasound of the AVF would be a good idea for early detection of potential complications? So I leave the floor to Dr. Malik and then to all of you teachers, of course. Please.
Well, my answer is yes, but to expand it somewhat, ultrasound is a very, very precise method. If you are educated and experienced enough, and you can both diagnose the stenosis in a very similar way to angiography, but also you can measure the flow volume, which is very important for assessing the clinical relevance of the stenosis. And my experience, but not only mine, but also in the literature from other countries, is that many patients that have some severe stenosis were not diagnosed as a dialysis unit, but they were sent for such a regular ultrasound examination, and the stenosis was detected there. We also did a study that confirmed this approach. The problem is that the current guidelines do not support the ultrasound surveillance, which is not a good idea in my eyes, because ultrasound is something we or at least you all will use in your departments, and as you use stethoscopes, and nobody is telling you do not use stethoscope, but this is the same way if someone would tell you do not use the ultrasound if you have it and you know it. So this is my point of view, and I am ready for your questions or comments.
Mm-hmm.
Okay, so I don't know if Dr. Lomonte, Dr. Ibes wants to add something, or if there is the person that raised this question who wants to add something else, if the question and answer were good for him or her.
It may be important to know that Spanish guidelines and European surgery guidelines, vascular access guidelines recommend ultrasound for surveillance, arteriovenous access surveillance, but KDOQI and European best practice do not recommend vascular access native for surveillance. That is against the surveillance in arteriovenous graft.
This is an important comment, Carlo, because I think that for all of you as residents that you have to create your own criteria, you should recognize that you have the guidelines, you have beyond the guidelines, the last articles, you have the experience of your hospital, but you have to be able to create your own criteria, trying to understand the different articles that are going to be incorporated to the next guidelines probably. And this is important because the difference between the two guidelines, that some of them, the IRA and the DOCIT says no, and the Spanish or the ESVS surgical one says yes, you should understand that when you read the letters, all the content of the guidelines, why is the reason that these guidelines justify this? Because perhaps you could be agreed with ones or with others. And this is important because the reason for what the guidelines says that you should advise or not is because for the surgical and for the Spanish guidelines, we think that there is enough evidence to advise the surveillance. For the European and the American one, they think that perhaps good, but there is not enough evidence. What's evidence? Well, you should realize that for say that we have enough good results with surveillance is because we get to increase the primary patency, the primary assisted patency, and the secondary patency. Primary patency is from the fistula creation until the first procedure to maintain the patency of the AVF. Primary assisted patency from the fistula creation, including all the PTAs or surgical procedures until thrombosis. And the secondary patency is even the fistula thrombosis until all the patency in the AVF until AVF loss. So there is a lot of evidence that say that with surveillance we can get primary patency and even primary assisted patency. But there is only 1 or 2 trials that says that the secondary patency can be got with surveillance. So the interpretation of the Spanish ISBS says that, well, if we get primary assisted patency and we decrease the number of catheters, this is enough for our patients. And the DOCI guidelines, the European says, well, this is good, but we need more evidence and secondary patency and so on. Then if you are enough confidence with that, perhaps if we don't have enough evidence, it's because there is not enough trials, then you should use surveillance. If you are waiting until to have the best evidence with 5 clinical trials in the next 10 years, you have to wait to check these trials, and then your patients are going to lose the opportunity to use surveillance. For the reason as important the guidelines comments are to interpret the guidelines. This is a crucial point.
Yeah, it's important to know that the surveillance should be based on the flow measurement. Oh, in your opinion, Jan or Jose, is the flow important more than stenosis itself? Well,
this is probably the summary of the content of this. The major part of all the content of our slides. The criteria based in imaging is history. The criteria based in hemodynamics, only the velocity inside stenosis, is history. This is from the past. Now that we need is the flow, as you say, Carlo, because this is the clinical expression of the clinics. It's like the vascular surgeons in lower limb stenosis. Perhaps you have an important lower limb stenosis, but if the patient can walk, are you going to operate this patient? Or for instance, like Malik is cardiologist, are you going to treat a coronary artery with a stenosis of 40 or 50%? And are you going to treat a venous stenosis of 50 or 60%? Has no sense.
Yes.
The nephrologists, you are clinicians. You take the decision depending on the clinical of the patients. When do you advise to patients to do dialysis in chronic kidney disease? Depending on filtration rate or depending on the clinics of the filtration rate? This is important, the comment of Carlo.
It's important for the residents, yes.
Any comment of this, of all of you?
Do you agree?
Thank you very much. That was my question. Thank you for your explanations.
Very good question.
A pleasure.